in those extreme cases. So today I'm going to talk about something that's actually evolved since I was a GI fellow, to the point that we may be curing it, or getting close to it, and we certainly may be also preventing it. So all of this work has really been due to the work of the NIH Gastroparesis Clinical Consortium. This is a group that started in 2006, I think, we first got funded. And so now we've been refunded 3 times. And we're kicking on using your money, hopefully spending it well, to address an entity which requires lots of centers to work together. We don't always have the critical number of patients in one place, and integrate all these patients and studies and try to come up with what's the next thing to do, what's the right thing to do, how can we solve this problem. So I've got some slides about what the NIH Consortium has sort of done for you lately, but I think in the time I have allotted here, I want to get to what I would call the really good news is what can we do for patients this minute, and indeed the fact is that we may be curing it in patients with severe gastroparesis. So I'm going to leave some of these next slides to the question and answer section. These are a number of slides that I wrote about the consortium, but I want to get to what is gastroparesis? So we all agree, I think, on it, but let's just make sure we're on the same page in the room. This is a condition where after searching high and low, we don't have a mechanical obstruction. We have very predictable symptoms, early satiety. Early satiety means premature fullness, you can't finish your meal, is the first step. And then we go to postprandial fullness, degrees of discomfort, even pain, nausea, could lead to vomiting over the next 3 or 4 hours, and sometimes a lot of gastroesophageal reflux occurring because of the stomach that's not empty. Goes on to weight loss, malnutrition, dehydration, electrolyte imbalance, hypoglycemia if you're diabetic, poor control, ER visits, hospitalizations, basal formations, aspiration pneumonia. It's a sequelae of things that lead to debilitation, as some of you may attest to. And it affects about 4% of people in the United States. So people say it's pretty rare. Well, it's not, because most of my patients think they have sprue or gluten enteropathy. That's actually 1 to 2% of real life. Hepatitis C gets a lot of press. That's 2 to 3%. So gastroparesis is alive and well, unfortunately, and very common and increasing. As diabetics increase, metabolic syndrome increases. These are dominated by females in the prime of life, working, trying to raise families. Median age is 50. So, who has this entity? Well, this is a pie diagram of the people sort of in my waiting room. But we could focus down a bit more. It's probably 40 to 50% different places in the country. I know parts of Texas are very hypermetabolic syndrome city. A lot of obesity and a lot of diabetes, hyperlipidemia, etc. So I see 40 to 50% of my gastroparesis stable patients are diabetic. But I wanted to bring out on this slide an evolving area which is called idiopathic. So idiopathic is you come to us and we say, we've done all the right studies, we've had all these diagnostic tests, we have no objective evidence of a single entity. But then you become a detective. Most of GI in motility is putting on a detective's cap and trying to sleuth and find clues. But this is beyond internal medicine. It's beyond many gastroenterologists. This requires a focused, dedicated motility center to sleuth out the clues. Now, post-viral is the going theory. You went on a trip, you went camping, you had food poisoning, we all get it, vomit for a couple of days, diarrhea, bounce back, go to work, it's almost forgotten. But apparently some of us have a very vicious bug. We're receptive to perhaps not being able to respond quickly, overcome it. We have some damage to our enteric nerves and neuromuscular function. And this will probably live on. It's like a bit like irritable bowel syndrome, where we say, you know, why did it happen to me? I'm a healthy 35-year-old female, wandering in your office. Well, post-infectious irritable bowel, post-infectious gastroparesis is an entity we've accepted. We don't have footprints, we don't have biopsies of viral particles, inclusion bodies. We're developing maybe some sort of database of serology where we can try to find out are there any markers for viral infection. But that's the going theory. If you can't, after third degree interview, you can't get something specific, you have to say you may have forgotten that you had a gastroenteritis illness, this may be a sequelae. But hidden in between this are an evolving area of entities that we don't have, we have to start focusing on more. You shake hands with the patient, they have cold fingers and hands. 10% of females have cold fingers and hands at a cocktail party. You don't really take them aside and interrogate them. But if you did interrogate them, 10% of those patients would have arthritis, dry mouth, dry eyes, Sjogren's syndrome, dysphagia, heartburn. And they have the markers of an indolent connective tissue disease. Their ANA be positive. Their SC37 or antibody test may not be. I don't get it. It's just wasting money. We know this is a latent connective tissue disease. And it's going to be involving your esophagus and your stomach and your small bowel. And that's probably one of the major causes of unexplained pseudo-obstruction. It's probably an evolving component of connective tissue disease, which has no treatment, except if you get the bad joints, you get on some of the biologics and some of the more big league stuff, but we don't do that at the basic level in the GI tract. Then there's this new entity called hypermobility syndrome. These are the double-jointed patients, probably most of the New York Ballet have hypermobility syndrome. They can bend fingers back, they can touch toes, you do these Brighton maneuvers in your office and see if you meet the criteria. And that's okay. You know, I have medical students who have hypermobility syndrome. We don't take them in and examine them more than that. But some of those patients have a component of Ehlers-Danlos syndrome. There may be a connection genetically. They may have POTS syndrome, where your pulse rate goes up and your blood pressure drops. And you have a component of either rapid gastric emptying or gastroparesis. You have an autonomic dysautonomia condition. And that's evolving more and more in young females, where we thought it was idiopathic. It's really not. It's connected to dysautonomia. Then there's a condition called the median arcular ligament syndrome. This is a band of tissue, ligament just as your celiac artery comes off your aorta, the first branch in the abdomen. It's compressed, it's not the celiac artery. Stomach has more blood than you can shake a stick at. It's compressing the celiac ganglion, and the celiac ganglion causes pain and gastroparesis if disturbed. And pain, it's the same ganglion we inject for chronic pancreatitis to try to stop pain. So here, pain, severe pain, out of proportion to objective criteria, combined with nausea, degrees of vomiting, and a slow stomach, you think of the median arcular ligament syndrome. It's diagnosed by a Doppler blood flow study. Then there's multiple sclerosis lurking in the background, subtle CNS degenerative disease, which is early, and we're going to be learning more about it, but it probably definitely affects the gut. Certainly Parkinson's is the more flagrant form of that. A latent paraneoplastic syndrome, you could have small cell cancer of the lung. Breast cancer, there are antibodies released from cancers which block your gut. Miscellaneous endocrinopathies, Addison's, thyroid, and degrees of unexplained dyspepsia, which we think could be related to undiagnosed or unappreciated gastroparesis. And then what we're seeing out there is, when I interpret a gastric emptying study these days, we have to be detectives because there's so much marijuana present. If you smoke marijuana, you may feel hungry and you may feel transiently good, but you're actually slowing gastric emptying. Marijuana slows gastric emptying. So we have patients come in, we do a urine screen the morning of their gastric emptying because we have to interpret that study later that day. And we usually medicine people don't do histories. So we obtain a lot more information. Opioids are stopped before the gastric emptying, diabetic medications, pramlintide. There are many things that can cause so-called idiopathic gastroparesis, which have to be very focused to make sure you don't overdiagnose this condition. Some of it is man-made. And then we have the other patients here. I think we've covered doing a vagotomy. Surgeons do fundoplications every day. They do a good job, but 1% of the time their number comes up and they're going to damage the left vagus in the chest, is the anterior vagus in the stomach, and we're going to have post-vagotomy gastroparesis and possibly dysfunction of the small bowel and small bowel bacterial overgrowth and all those things. But diabetes, as I said, tends to dominate, and what we find when we study you've got, this is up close and personal in your stomach. This is your smooth muscle. We have the enteric nervous system over here, or Bach's plexus, more than 10 to the 6 neurons and more than the spinal cord, distributed into smooth muscle, connected down here to the interstitial cells of Cajal and the smooth muscle. Interstitial cells of Cajal are cells near the enteric plexus which determine your electrical rhythm. All of us have 3 cycles a minute: running, eating, sleeping. You can only contract 3 times a minute. You may feel hungry, you may feel like you want to eat a lot. It's not going to go that fast. It's going to be 3 times a minute. Your stomach contracts, triturates the food, and pushes it towards the pylorus. So if you have deficient cells of Cajal, normally you have more than 10 per high-powered field, you're deficient, you have problems with what's called electrical dysrhythmia. If you measure the electrogastrogram, put your electrodes on your tummy, and measure your electrical rhythm, if you have less than 10 cells per high-powered field of cells of Cajal by CKIT staining, you'll have tachygastria, or irregular rhythm. If you're normal, ICCs, you'll have a pretty good regular rhythm. So these are things we're learning about the sort of the engine. How do we coordinate and integrate gastric smooth muscle, enteric nerves, and the mind and the electrical rhythm when we eat? So what we've come down to is this. This is in diabetic animal models and in man. We're living in symbiosis, as we do in many areas, particularly diabetes. So when you have a lot of M2 macrophages, you're making and protecting heme oxygenase, protecting interstitial cells of Cajal, and nitric oxide, and enteric nerves, and you have normal gastric emptying. There comes a point, either post-inflammatory, degeneration based on continuous diabetes, sorbitol metabolism, myonisitol metabolism, Wallerian degeneration, inflammation. Inflammation is probably the key that you now lose M2 and go to M1. When you go to M1 macrophages, you deplete heme oxygenase, you impair interstitial cells of Cajal, and you impair enteric nerves, and you get gastroparesis. So what we're doing now with the consortium is identifying drugs which we could take early in our career, diabetes or even unexplained nausea involving gastroparesis, to prevent the move from M2 to M1, which will in turn form a cascade of events which will make your gastroparesis worse. So this is at the early prevention molecular stage. Now, part of getting there is to be able to get biopsies. So right now we're limited. We only biopsy your stomach at surgery. We can biopsy for H. pylori and all that stuff in the mucosa, but that's not relevant to this. We need to get smooth muscle. We need to go down to your deep muscle. So there's two ways of doing it. You can do endoscopic ultrasound, where you put a needle through the endoscope under ultrasound guidance and biopsy smooth muscle. You can get some pretty good stains and pretty good tissue. And now we're doing what's called endoscopic mucosal resections, where we cut through the skin of your stomach, make a little incision, and go underneath the skin. There's a little potential space, a little tunnel. You go into the tunnel and take a biopsy of the muscle, which is deep in the tunnel. And that's going to allow us when you come to us and you have those symptoms, we come to a stop point. We can't really deeply look at your muscle and tell you what happened. What sort of shape are you in? You will now get a routine endoscopy where the same day you'll go back to your hotel. We will penetrate and obtain muscle from deep in the smooth muscle. Could be in the rectum, could be in the small bowel, could be in the stomach. And we can tell you what happened. Is this scleroderma? Do you have loss of muscle? Is this enteric nervous system ICC loss? Have your ganglia been infiltrated by inflammatory cells? This is evolving. Let's talk about today what you can look forward to and what is happening. So this is a menu, and you've all been through it and up and down it and around it. I'm not going to go through all that right now. I'm going to just cut to the chase and tell you sort of what's beyond the chapters in the textbooks that you're reading. So this is the pipeline right now that you're going to look forward to. Beyond aprepitant, beyond zofran. We're working on urocinin substance P antagonists. One is called tradapatent, and it is in phase 3. It looks very promising. It's just been an announcement. The first series of studies were positive, and we're going to be going into another trial to try to get this approved as an antiemetic. As far as a prokinetic, you have the ghrelin agonists. Relimoral is on phase 3B studies right now. Looks promising. It's given subcutaneously. Stimulates motility. It's the hunger hormone. In the 5-HT4 agonist world, prucalopride was just approved. It was developed by Shire initially. They were bought by Takeda. So now it's a Takeda drug officially. It'll be released in May. And it's a 5-HT4 agonist. It's like cisapride was 20 years ago. And it will help the stomach, the small bowel, and the colon. It's going to be a very big drug. Has no cardiac effects, as did tigazoline and cisapride. And then the most exciting, I think, are the new dopamine 2 and 3 antagonists. The best drug in the world is domperidone, as far as nausea, vomiting, and gastroparesis. It blocks nausea in the brain, stimulates motility in the gut, down to the mid-jejunum. It's not too far down, it's distal duodenum. Its trouble was it prolonged QT intervals, and we had a risk of cardiac arrhythmias. That's gone. We have 2 new drugs, particularly this one by Takeda, which is now in phase 3 studies to block nausea and stimulate motility. very exciting agent. Metoclopramide has got a nasal spray which might help patients who are very nauseated, can't swallow, and there's another drug from Europe. So let's talk about what's beyond stimulation. So this came in 2000. Those of us who were around then thought it was wonderful. In actual fact, Medtronic sold us a bill of goods, nice people, but their only goal is to make money. They may say they want to advance research, but that's not their boardroom discussion. So they took these devices off the shelf that were being used for back pain, neurostimulation of the spine, and they made out that we could manipulate the programming and make it work for gastroparesis. So the theory was that we would put 2 electrodes here, 9 and 10 centimeters from the pylorus, suture in the smooth muscle, and come down to a pocket subcutaneously placed in the rectus muscle below the skin. And we would turn it on at a neurostimulation, low energy level. We're massaging and vibrating your smooth muscle. We're going at 330 microseconds for 0.1 of a second every 5 seconds, 12 times a minute. And so 12 cycles a minute, 14 hertz. And we did a double-blind study back in 2000. 1 month on, 1 month off, double-blinded beginning of surgery and crossing over. And here you see the diabetics in red look good. If you look at everyone who was on, diabetics were better than idiopathics and significantly better than their baseline, compared to idiopathics who are a little shaky. And this is the total group. And over 12 months, they were sustained and maintained. And this looked very promising. But when we went back and began to look at why does it work, we found a lot of things out. We put electrodes on the stomach. We measured gastric emptying continuously. And we did some studies on the brain with a PET scan. And we showed that nothing really happened here. We did not increase or change electrical dysrhythmia, not improve it. There's no electrical sequelae. This is beyond pacing. We're not pacing the stomach. We're vibrating it. And the most redeeming feature was the vibration went up to your brain and it blocked nausea based on this PET scanning. Thalamus and caudate lobes were involved. And it relaxed the fundus a bit because it stimulated vagal action. It was more vagal than sympathetic pathways. So it's an antiemetic. When all the blankets are taken away and we expose it, it's an antiemetic. A unique pathway, which Medtronic discovered, if you like, from the stomach to the brain. It may overlap acupuncture, it may overlap stimulating P6, the acupuncture point in the finger, in the wrist. It goes up to the brain, but this is done in the stomach. But it doesn't change electrical rhythm, it doesn't change gastric emptying. So we were dissatisfied with that. I think our patients were too. We're not getting anywhere above 50% improvement. That's sort of the going rate around the country with many people. Got a bad reputation. Was put in inappropriately, number one. Anyone who vomited got one. White magic. No. And no one looked up the patients carefully. And it got a bad reputation. It may not work that well. Well, the reasons why is that we're taking on severe gastroparesis. Okay, this is 30 to 40%. The other ones are doing relatively well on diet, antiemetics, prokinetics, and maybe some psychotropic drugs for anxiety and depression. So what happened in about 10 years ago, and now into the last 5 years, is the pyloric revolution. The pylorus was neglected and not addressed. And so we began to wonder whether this little canal here, which has these phasic contractions that get tighter when you eat fat, they relax over time and let food out as you start to triturate. Could this be like achalasia. Sphincter doesn't relax, esophagus doesn't empty. So we know that when you do a vagotomy, the surgeons forever did a pyloroplasty. That was teaching in the 60s before H. pylori came along. I'm not sure surgeons know where the vagus nerve is now, but they do, when they did know, they cut the pylorus and opened it up. We're doing a vagotomy essentially in a dysfunctional component of gastroparesis, whether we cut the vagus nerve officially or damage it during fundoplication, diabetes, idiopathic, we're damaging the vagal enteric nervous system connection, and it leads to the cascade of depleting ICC, basal formation, food doesn't empty. So we began to say, let's add a pyloroplasty. Let's do something to help these patients. So we added the pyloroplasty. And when we added the pyloroplasty, cutting your pylorus with a knife, we took biopsies and we looked at those biopsies. And for the first time, we realized that these patients had much more loss of ICC. 80% of these patients had lost their ICC compared to controls. And they have fibrosis. 30 to 40% have significant fibrosis on a trichrome stain. So this changed the game. This meant that really, unless you could open the pylorus, it was very tight apparently, we would not get anywhere. So we moved into the world of trying to do that. Endoflip was developed, a device which goes into the pylorus through endoscopy. You blow a balloon up and you find out how tight is my pylorus, can it relax and accommodate to a certain size balloon. And then we went through the Botox revolution where everyone and their brother got Botox. Some of you may have been recipients of that revolution, of that era. Interesting era. Turned out it was no better than placebo, but we're never sure. Some people wondered, did the needle really go into the muscle? Things are moving. Endoscopically, you jam it in, but do you know you're in the muscle, you're in the serosa? Did you go into the peritoneum? It may not have been perfect studies, but for whatever reason, it's been left as negative. So then the surgeon said, well, we're going to get more aggressive. We're going to do laparoscopic pyloroplasties. Forget about stimulators, we're just going to move ahead. And they indeed have found that a subset, a number of their patients did improve. And we decided to also adopt the pyloroplasty, the McCallums approach, and combine that with gastric electrical stimulation. So the gold standard right now is to retain the neurostimulator in the name of nausea, because the muscle and the enteric nerves and the ICC are damaged. Surely that can do something to nausea. At the same time, we're going to cut your pylorus. This is a robotic picture. And we're going to put these electrodes in the stomach.